host and president, Chris Wojno. We have our vice president, Alex, in the back on the side there. Say hello. Hi, Alex.
Hi, Alex.
Thank you, everybody. You're so friendly. Today's events are brought to you, and this building is brought to you by you, paying members and guests who donate to our jar that keeps the place open and running and gets us speakers, wonderful speakers like you're going to be hearing today. So thank you for volunteering and supporting our mission. Who here really like breakfast? Yeah. Please, thank you, breakfast crew. Thank you so much. We can always use an extra hand for the breakfast time, and it's a good time to meet new people and make friends. So if you want to come in a little bit earlier and help us head up, then we'd love to have you. So thanks so much for volunteering for that. And if you don't want to come in early, you can bake a casserole. I think Kathy brought one in this morning as well. If you really like that casserole and you want to show her up, you can bring the casserole.
Linda brought one too.
Linda brought in a casserole as well. Thank you so much, Linda. So there's some competition here, friendly competition. I know you can make good casseroles, so come show us what you got. Anybody here have a cell phone? Nobody. Okay, so I don't have to announce that you want to silence that cell phone right now. Who's got a cell phone? Nobody. So we are membership supported. If you'd like to become a member, you can talk to James Osborne in the back. You can also talk to Elizabeth. She's on the computer as well. So to ask about membership, get a tour. We'd love to have you here. So please do consider becoming a member and supporting us on an ongoing mission. Anybody here for the first time? Awesome. Thank you so much for coming. Please welcome me. We are a welcoming community, and we hope that you get a lot out of this talk. You come back for all of our other cool events, which I will cover in a little bit. Anybody here get a pin for their first time? Maybe with a pin? No? Alrighty, we'll get you next time. So we have a couple announcements for today. We do have a board meeting right after talks. If you'd like to know how this process, this building stays afloat, and you want to come support us, you just want to voice an opinion, we'd love to have you. It's right after this at 12:30. Alternatively, you can go to lunch. You want to come up and announce lunch, Richard?
Sure, I can do that. Is this a good time for that?
Definitely. It's always a good time for lunch.
Right after breakfast, yes. I'm going to talk to you about lunch right after breakfast. That's a good point.
What about 11Zs?
11Zs? Yeah, that's right. I forgot about the Hobbit. 11Zs. So we do have lunch crowd going after, immediately after. We have reservations at a local restaurant at noon. And especially like to see the newcomers come and join us for lunch. It's the Mesa Community Restaurant. It's just about 2 blocks away, so it's really, really close. And even if you are full from breakfast, you can still come by and have iced tea and coffee and all kind of stuff. We have some great conversations there, and we're really hoping that we get lots of people in there and have some great talk. And you can find out a little bit more about what's really going on in the minds of humanists. So come on and join us. It's the Mesa Community Restaurant. I'll be hanging around up here up front after everything is over with today, so if you need directions to get there, just come up and talk to me.
Awesome. Thanks, Richard. So we're looking for somebody to help us document all the stuff that's going on here. We're looking for a historian. So if you're interested in helping us document all the work and things that we're doing here, and you've got a camera that works pretty well, we'd love to have you, and just come on and talk to me. Come on up and talk to me after the meeting. We're looking to fill our very first historian position. So, could be you. Thank you. We're also looking for somebody to help us out with the children's play yard. So if you're willing to put in a little bit of time every month, we could definitely use the help. Bill, you came back from Utah.
I'm visiting.
Bill did our children's yard before. He did a great job. Thank you so much, Bill, again. But yeah, we could definitely use your help with that. So if you're willing to come in, put in a little bit of time to help us get our children's yard looking, keep it looking real nice and safe for our kids, we'd really appreciate that. So come on up after the meeting. Okay, so we've got a couple of other announcements. I got to sit down my computer boxing. Anybody get this card in the mail from the Freedom from Religion Foundation?
Yes.
For everybody else, I'm going to read it to you. This is pretty cool. It's very reminiscent of what's going on with the atheist community of Austin, so I think you'll like it too. So FFRF's Free Thought Matters TV show is debuting in the Phoenix area Sunday, September 2nd. So we're pleased to announce, I'm reading the card, we're pleased to announce that the FFRF's new TV talk show, Free Thought Matters, will be airing weekly for 26 weeks over Phoenix TV station KASW-CW, that's Virtual Channel 61, UHF 49. Sundays, 8:30 in the morning. So you'll have to choose which one you want to do. No pressure, but it's going to serious. So if you're at home sick or for whatever reason you can't make it here, you can go watch that one. September guests include comedian Julia Sweeney, Harvard professor and FFRF honorary president Steven Pinker, science communicator Cara Santa Maria, you can't talk to me, and Evolution is True author Jerry Coyne. So all those are really big names from very cool people. The station reaches most of Arizona, and please thank the station for broadcasting TV from the secular point of view. There's an email address, I can give it to you if you want. And please spread the word and watch Free Thought Matters, because Free Thought Matters. So very cool stuff happening from the Freedom from Religion Foundation. A couple of meeting announcements here. Smart Recovery is every Monday, so if you're struggling with addiction or know somebody that's struggling with addiction, please come on by every Monday night at 7 o'clock. We're here till 8, and I have my office hours at 7 between the same time. So, we're doing Let's Eat Geography this upcoming Wednesday, August 29th from 12 p.m. to 2 p.m. And it was supposed to be on Suriname, but since there's no restaurants for Suriname, we're doing Caribbean food. So if you're looking to branch out, try something new, come on by. Go RSVP on Meetup for Let's Eat Geography. I don't know the name of the restaurant right now, but go RSVP and check it out. We also have an Acquiring Minds discussion this upcoming Saturday, September 1st. It's the end of the month already. You made it. It was cool this morning. I liked it. I could actually go outside and not melt. So anyway, September 1st from 9:30 a.m. all the way to 11:30 or noon or so. And then there's usually lunch right after, so it's a really good event to go to. This month's topic is very interesting considering what happened within the last couple of months, and this is about autonomous vehicles. So if you've got interesting questions or topics you want to explore with other people about vehicle autonomy and how they should be programmed, or how the economics of them work, or the ethics of them work, you should stop on by September 1st, this upcoming Saturday. Also on the same day, we're going to St. Mary's Food Bank. We're going to be building up probably emergency food boxes for the homeless and the hungry in Arizona. So if you want to come join us, please be there from noon to 3. We usually kind of go to lunch right afterwards, so if you want to join us for lunch, we usually just head over to a local Mexican restaurant. Just come on by, we'll tell you where it is. We also have TED Talks coming up September 5th. What's our topic for this month, Christina?
Medical advancement.
Medical advancements. So if you want to submit some videos of TED Talks and come talk about them, please sign up on our Meetup page, submit your videos, and we'll talk about your video.
Make sure they're from the TED website, please.
Yes, just make sure they're TED website videos, TED.com. And that'll be not this upcoming Wednesday, but the following Wednesday, September 5th, and starts at 7 p.m. We're going to be doing Sleeping Mats for the Homeless again on Saturday, September 8th. So Anita's still doing her crocheting mats for the homeless. It's a really good project, a lot of fun. If you don't know how to crochet, Anita will teach you how to do that in a very gentle fashion. She has assistants doing it in a very gentle fashion. That same day, on the 8th, we're going to be doing game night at 6:30. It's a lot of fun. Bring board games, bring card games, dice games, anything you want, and some food to share. It's a lot of fun. Come on down. And finally, our next Sunday speaker is going to be from Annie Damgard. She's a PhD, and she's going to be talking about her new book, Schizophrenic America. Do you feel as though this country no longer belongs to you, that it's yours? If that's the thought you've had recently, maybe more than once.
Just a little.
She's going to be talking about that in her new book, and she says, the United States is at a crossroads. We cannot afford a wrong turn. Each of us must answer questions such as, who am I? Do I live the life I once imagined that I would live? Do I like the person that I've become? Is my country the place I believed in as a child? So we're going to be discussing those very interesting ideas and topics at our next Sunday speaker meeting, September 9th at 10 a.m. Breakfast, as always, is at 9, and please bring quiches for competition. I'd like to take a second out real quick to read something that a member has passed on to me that they would like me to read in honor of the recent events. Now, regardless of whether or not you agree with everything this person has done, I think it's important to realize the passing of the type of person that they were. So, and I start begin here. An honorable man has passed away. Today, as humanists, we have the opportunity to act upon one of our humanist principles, respect of another human being. I ask that we stop for 1 minute out of respect and have a moment of silence for his service. Eventually, we were not always in step with his choices that he made. Arizonans have Arizonans have lost one of the congressmen who had served honorably, Senator John Sidney McCain III. So I'll take a few seconds here. So thank you for that. Maybe we didn't always necessarily agree with his decisions, but I think this marks a change in the way things have been done recently. Okay, so I'd like to invite Christina to come up and give our Humanist Minute real quick here. Our Humanist Minute is where we like to talk about something that really emphasizes the humanist philosophy. And Christina is our TED Talks leader. She's been a member for quite some time, and she's pretty awesome. So please give her a minute here for our Humanist Minute.
I don't know if I'm that awesome, but okay. I'm sure we've all seen recent news about Alex Jones getting deplatformed, and I'm sure we all have our own personal opinions. But it's definitely sparked a debate about freedom and free speech. So it got me to thinking, and I found this wonderful quote. Sorry, can't talk this morning. This wonderful quote from Nelson Mandela that I would like to share with you. For to be free is not merely to cast off one's chains, but to live in a way that respects and enhances the freedom of others. Thank you.
Thank you, Christina. Nelson Mandela wasn't necessarily strictly a humanist, but I think we can all agree that that's a big part of our values here. So if you'd like to do a Humanist Minute, we'd love to have you. If you've got some little quote or something that you'd like to bring up, or a story, it could be personal, it could be not personal. It's one of the two, but it could be mathematical. I don't recommend it, but it could be mathematical. We'd love to have you as our Humanist Minute, and thanks so much. So at this time, I'd like to bring up Pam to introduce our speaker.
Good morning. I'm very excited about our speaker today. Let me share a little bit about her, but first to say a big thank you to Bradley Lusk for introducing me to Heather and her team. It's been really nice communicating with all of you, and thank you. Dr. Heather Ross is a nurse practitioner at Arizona Arrhythmia Consultants and professor at ASU in the College of Nursing and Health Innovation and School for the Future of Innovation in Society. Her teaching focuses on health policy and technology policy, and research focuses on next generation wearable sensors in complex socio-technical systems. She is a trustee of the Heart Rhythm Society and chair of the Cardiovascular Team Advocacy Committee of the American College of Cardiology. Dr. Ross is also a 2018 candidate for U.S. Congress to represent Arizona's 6th district. And I wanted to share a few other background things that, she gave us some wonderful information. Heather was born in Phoenix and raised in Scottsdale, Arizona, the oldest of 4 children. Heather attended public schools throughout her K through 12 education and graduated with honors from Horizon High School at the age of 16. She was accepted at Yale University to study molecular biophysics and biochemistry, a really breezy. After college, Heather pursued a nursing career at Boston College. There she discovered a passion for cardiology that led her to a career as a nurse practitioner to this day. She joined Arizona Arrhythmia Consultants as a nurse practitioner in 2008. While caring for patients and raising her family with her husband, Heather earned a Doctor of Nursing Practice degree and a PhD in Human and Social Dimensions of Science and Technology, both at Arizona State University. So we're very excited to hear Dr. Heather Ross. Please help me welcome.
Thank you. Thank you very much. That was a very kind introduction. And Pamela said, I know you gave me this bio to read, and that was the first part she said, but I'm going to go off script a little bit, and I'm going to, cheat and break the rules. And I said, it's not cheating, it's quilting, right, when you put different pieces together. So thank you. Thank you, Bradley, for bringing me into this space, and Pamela for helping us be here. And thank you for all of you for being here this morning, and all of the mornings that you're here, because this is really a lovely community. And of course, a community is only a community if there are people in it, right? So thank you for making that happen. And I have to also thank my campaign team for giving me permission to be here on the 2 days before an election. I can assure you that later in the day, I will not smell nearly as delightful as I do now, because I will have been out knocking doors, trying to make sure that we have every last ballot turning in on Tuesday. One of the things that we talked about in a conversation this morning was how many people have expressed that they're choosing to not engage with our electoral process right now, and how disheartening that is. And I am heartened to be able to be part of that process, and really re-encouraging everyone to exercise their voice. And the way that we can exercise our voice in our communities is not only by speaking, not only by being a part and constructing a community like this, but by, here in Arizona, drawing that line on the ballot, right? Connecting that arrow and turning that ballot in. It's something that is so very precious, and I am incredibly grateful to have the opportunity to talk with people in my local community across Arizona, and frankly across America, to remind us how very precious that is. And so I really owe a debt of gratitude to my campaign team for allowing me this time with you, and thank you for allowing me a piece of your space and community this morning. So we're going to talk about unraveling the mystery of our healthcare system. Let me assure you, we're not going to solve it this morning, okay? This is not, our healthcare system and the problems that we have with our healthcare system in America are not something that can be solved in a day, in a year, in 4 years, Probably not in 10 years, but it's a process. And we're going to work at unraveling some of those mysteries. Because when they're at the end of the day, they're not mysteries, right? There's a lot of science, there's a lot that we know. And one of the ways that we must approach this problem of health in America and healthcare in America is by remembering that we must always privilege what we know. And that must drive what we do and how we go forward. So I'm gonna present you with some information, some things that we know, and then some ideas for how we can think about taking those things that we know and moving them to where we want to go, okay? Believe me, I am real good at standing up in front of a group of people and saying, we are going to learn you a thing today, and I'm going to tell you a lot of stuff. But we're not going to do that today. Rather, I'm really counting on you, a really engaged group of strong thinkers, to engage today and to have a conversation. Because these are some big ideas. I am never going to be the person who says, snap, we can just, draw a box and make a list and fix it, okay? We're gonna say, yeah, we can fix it. But there are some really big ideas that we've gotta bring into the fold and put into action. So I'm gonna talk to you about some of these ideas, and I really, really want to hear from you. And not just wait till the end and do a Q&A, but when you feel like you've got the thing to say, I need you to say it, okay? And we're going to have much more a conversation than a lecture. And my students will tell you, I can talk at you for a long time. We're not going to do that today. Okay. So let's all make sure we're kind of on the same page. This is not going to be shocking information to any of you. This chart shows relative spending. My apologies to anyone who has trouble with color, because this is very colorful and a lot of the information is conveyed in color. Even if you can't see every data point, on this slide, and let's see, I think we may have, okay, so these are all countries here, and this talks about the percentage of GDP that each country spends on healthcare. And you can see that most of the information here, most of the rainbow here is down, sort of clustered together in this say 9 to 11.5% of GDP. And then here's the United States that's spending, this was in 2013, 17% of GDP. And in fact, in the last 5 years, we've seen that climb up to about 18% of GDP, our gross domestic product. We spend almost 1 out of 5, dollars of our gross domestic product is spent on healthcare in America. So one would think that, you get what you pay for, right? That's what my grandmother told me. Well, let's see if that works out. As it turns out, that doesn't work out so well. These are a lot of the same countries we see listed down here, some more countries. This is life expectancy at birth, is what we see here. And now, in no way do I want to suggest that health outcomes can be entirely represented by life expectancy. But bear with me, let's use this as a proxy measure, okay, of health outcomes. Let's just pretend for a moment that this is a substitute for the universe that encompasses all of the health outcomes and all of the ways that we can understand health outcomes. So we see that Japan, life expectancy at birth is 84 years, okay? And kind of steps down, and then we've got countries here like Cyprus at 82 years. We've got Ireland here at 81 glorious years of boiled potatoes. And, then we've got places like Chile and Lebanon. Lebanon with a really long-lasting war situation happening has a life expectancy at birth of 80 years. And then here we've got the United States with a life expectancy at birth of 79 years. Now you may think that the difference between 79 and 84 years is, oh, it's only 5 years. Well, think about what 5 years means in your life. Think about that. Think about what one day means in your life. And think about what losing those 5 years. So, we spend the most and we get the least, relatively speaking. Okay? Here's another way to look at it. This is a slightly more complex graph. Healthcare spending versus health outcomes. Again, as healthy life expectancy at birth. This was in 2003, so this chart is a little bit older. Total healthcare expenditure per capita, so measured a little bit differently. The 2006 or latest, so this was published in 2008, or these data were coming from 2008. And I really like this chart for many, many reasons, including that it helps us with some qualifications. Okay, so here we have efficient up in this corner, we have underfunded in this corner, we have effective up in this corner, and we have wasteful down in this corner. And here's what we can notice when we compare health outcomes to healthcare expenditures at the country level. We can see that by and large, there's this cluster here. We can see that there is a relationship between life expectancy and expenditures, moving from underfunded up to effective, efficient and effective. And we can see that most countries fall along these lines. We can see that places like Poland and the Slovak Republic and Hungary, places that in the past 70 years have had to really come back from just almost total destruction in many ways, are indeed underfunded, but leaning towards they're efficient though underfunded. And then we've got countries like Switzerland that with really beautiful watches and chocolate together, like you can really get to the top of the class if you just have those two ingredients, I think is what we should take away from that, right? And here we've got the United States, way out here on its own. And so how do I interpret this? Well, I interpret this as saying, one of these things is not like the other. Remember, wasn't that from Sesame Street? Yeah. Like what? And here's a life lesson: when Sesame Street tells you something, you really should listen, and you should carry this forward. So when one of these things is not like the other, we should take a really critical look. And we see that the United States is out here. Really the closest to wasteful. We're so much more close to wasteful than Hungary is down here in the underfunded, our next closest neighbor to the wasteful corner. And so this tells me there's something we've got to do better. There's something we've got to do better. We're spending the most, we're not getting what we pay for. Okay. So that's a set of information that now we're all on a similar page. There's another set of information that I really want you to know, and it has to do with determinants of health. When we look at the components, there are 5 basic components that determine our health and frankly our risk of premature death. And a gentleman named Eugene Schroeder in 2007 delivered a talk in Boston. Now, if anybody's ever been or lived in been to or lived in Boston, I did. Yeah, thank you. I did my nursing training in Boston. If you've ever encountered the healthcare industry in Boston, you will know that people in Boston think that all healthcare is in Boston. And really there's no other conversation worth having about healthcare outside of Boston. So whenever I see these data from Dr. Schroeder, I always think, well, obviously it was in Boston. So yes, he's a Boston guy. Anyway, I digress. There are 5 major components that go into health, determinants of health. And he was able to quantify what each of those components contributes, how each of those components contributes to determining health. And we see here, and again, apologies to people who have trouble with color, so let's walk through it together. Here we've got, well, let's look at the biggest chunks first, because I think this is useful. So here in red at 40%, behavioral patterns. Okay, behavioral patterns make up 40% of the determinants of our health. The next biggest chunk, if we come right across the way here, 30% genetics. Okay, so our genetic predisposition, we can't do anything about. Like the bags under my eyes and the size of my hips, I would like to thank my mother. And, you know, there are some things I can do about that, but like that DNA is, you know, a lost cause. Let's see, our next biggest section here is social circumstances at 15%. Environmental exposure here is at 5%. I did deviate from my downward track. But so here we've got 90% now of our health determinants accounted for. And what's the last 10%? Healthcare. Healthcare contributes only 10% of how our health is going to be and our risk of premature death. Yet healthcare accounts for 18% of our GDP as a nation. Seems to me like there's a disconnect there. So here, so we're all kind of on the same page. Now, if we look at what are the things that we really can control in this pie? Behavioral patterns, 40% of our health and our health outcomes we can attribute to behavioral patterns. That's quite remarkable. Another 15% here, social circumstances. Again, that's something that as humans, we have all of the control. We have all of the control over more than half of the determinants of our health. So as we think about our healthcare system, I would suggest that we think about what we can control. We certainly can control some of this up here, but let's think about most of what we can control as we think about how can we get our healthcare system maybe a little bit closer along this line and to look a little bit more like some of these other countries that have a greater, really bang for their buck, and be down here, okay? So, are we all kind of on the same page with this basic set of facts? Yes, Bradley.
So then, what's leading to us living 5 years younger? Do we just make bad choices? Are we more prone to taking risks than the Japanese? Or?
Sure, the question is what's leading us to living 5 years younger? Are we just making bad choices? Yeah, I can tell you today from the perspective of a healthcare provider, also a parent of teenagers, there are a lot of bad choices that are made out there in the world. There are so many good choices, but a lot of bad choices, and that's something that's really important to consider. And let's think now about how we might frame bad choices. We can frame bad choices at the level of the individual. We can frame bad choices at the level of community, of informal community or more formal community, as we understand municipalities and states in our nation. We can frame bad choices most certainly at the level of policy. Believe me, I'm not running for Congress because I think we're making all the right choices at a policy level. If I thought we were, I would say, let's leave it in the hands of the people who are doing it. And listen, I have a great professional life. I get to be in this incredible, thriving intellectual community at Arizona State University and really spend time thinking about the future and innovation. I mean, for heaven's sake, the two colleges that I'm appointed to at ASU both have the word innovation in the title. And my major appointment, my office is in a department called the School for the Future of Innovation in Society. Like, that's what I get to think about every day. It's amazing. It's amazing. Believe me, I am not running away from that. I'm running to public service because I know that as a society, not only can we do better, but we must do better. And I will share with you, we had a tribute in a moment to think about Senator John McCain. 25 years ago, I had the opportunity to serve as an intern in Senator McCain's office. And one of the things that he told us, the intern class that year, he said, listen, we need good people to serve in government. So if you ever have a thought that you might want to serve and go into public service, please do, because we need you. And so it seems very fitting. Of course, we will all miss him in some different ways. But I think as a society, we will certainly miss him. But it seems very fitting that as I think about how we must do better in our healthcare system, and I have the opportunity to share some of these thoughts with you this morning, to know that my impetus for seeking public service opportunity came from Senator McCain. We can remember today. So, bad choices. We know not only from lived experience, but we know from data. We know there's evidence that, yeah, most of the determinants of our health and our risk of premature death, the biggest chunk of it comes from behavioral patterns, bad choices, okay? And social circumstances, and you can frame social circumstances as what's the foundation for social circumstances? In so many ways, it's policy. And that's a big part of it too. So I think, did you have a question back here, and then we can come over here?
I'm just wondering, for the healthcare, does that include behavioral services? Or?
Absolutely. The question is, does healthcare include behavioral services? Well, it's a great question, and my gut reaction is to say absolutely, because my approach to the vessel of the human body is to understand that behavioral health services and mental health services, however you care to term it, I think of it as very much integrated. Now, our policy frameworks today in America don't integrate mental health and behavioral health in the way that I believe it should be integrated, and that I am always advocating for integrating. So great question, and yes, I jumped to say absolutely, but the reality is that we've got a lot of work to do to get to that absolutely. And then you had a question, Rita.
Well, more comment. Wouldn't behavioral patterns include the typical American nutrition-free diet?
Yes, absolutely. Thank you. The question is, would behavioral patterns include the typical American nutrition-free diet? And that was a quote from Anita, not a quote from me. Yes, absolutely. And that's the choices that we make, and that's a set of individual choices, but also a set of social circumstance choices that we make. You know, I have many patients who can't afford to buy vegetables. They don't, well, there are subsidies issues, but there are also issues in America with food deserts, transportation, access to food, to fresh fruits and vegetables. There's also the observation that when you are planning, your calories, that now I always need to eat more vegetables because they're not calorie dense, right? I really like to eat, but I would refer you back to my DNA and, you know, this action down here that would suggest that I need to focus a little bit more on vegetables and a little bit less on things like mashed potatoes, okay? Which technically is a vegetable. But when a family is struggling to make sure that they can put enough calories into their kids, right? Vegetables are really expensive calories. Potato chips are really inexpensive calories. And so that we have to understand feeds into quite a bit of the choices as well. Yeah. So, yes, back here.
Can you talk a little bit about what social circumstances are?
Absolutely. Thank you for the question. What are social circumstances? Social circumstances includes one's economic capacity to navigate through society. That's, if we're going to boil it down, it's one's economic capacity. So social circumstances and economic ability plays a huge role in where you live. Are you living in a close-quartered environment that may have a lot of mice and rats, that are creating a lot of droppings, that are exacerbating your child's asthma? Are you in a situation where you have to work 2 or 3 jobs? Are you limited in where you can live because of the transportation access that you have in a municipality, or that you can afford if there's not public transportation opportunities around? Are you living in a place, or are you surrounded by people who may have a set of behavioral practices that are negative or influencing you in a bad way? Do you live in a place where you can't go out for a walk, or your kids can't go to a playground because you're concerned that they're going to get stuck by a used needle that somebody left under the swing set? And that's social circumstances includes a lot of that. All of that, in fact. Yes. Yes?
Could some of that nutrition problem be part educational?
Could some of the nutrition problem be part educational? Most certainly. When I was a nursing student, one of the rotations that I did was through a cardiac rehab program. Now, I trained in Boston, which I would remind you is the epicenter of all medicine in the universe, right? But I was so fortunate that I learned in this cardiac rehab program in what's called the Mind Body Medical Institute. It's part of the Beth Israel Deaconess Medical Center. And this cardiac rehab, a lot of cardiac rehab is, you go and you exercise and you get your cardiovascular fitness, and you go on the treadmill or on the bicycle or what have you, and you've got wonderful exercise physiologists, looking after you after heart surgery, for example. The Mind Body Medical Institute did that in its cardiac rehab, and then it did a cooking class, and then it did meditation and or yoga, which is moving meditation, if we're being honest about it. And so, education, absolutely. I grew up understanding that cardiac health relies on nutrition in so many ways. And I came to understand in my education that not everybody has had that nutrition education. And so we have a responsibility as healthcare providers and as a healthcare system to make sure that everybody knows that, prime rib is really calorie dense and has a lot of saturated fat in it that's really not great for your arteries compared to chickpeas, which also have protein, right? And that it's so important to have protein and fat and carbohydrates. And it was shocking to me as a young nurse to understand that not everybody knew that, and really helped me understand as a healthcare provider that I needed to spend time making sure that my patients knew that. Also accommodating one's economic capacity and social circumstances. Now, I grew up as the child of teachers, and I remember when my dad would get paid during the school year. He was an elementary school teacher, and we had some years what we called Peanut Butter August. Now, does anybody know what Peanut Butter August is? Yes, a lot of you do. Maybe you were a teacher or you had a parent as a teacher. Peanut Butter August is when the paycheck stops coming in May, right? And it starts up again in September. In Arizona now it's August. But back in the day, it used to be September. And Peanut Butter August was when, come August, and the savings is dwindling for the summer, peanut butter is the most economic form of protein. The best way to get protein into kids, the cheapest way to get protein into kids. So I had peanut butter in every form. I had peanut butter on crackers, on bread, on celery, on a spoon. I had peanut butter soup. I had peanut butter mixed into pasta. I mean, we ate like a lot of peanut butter. And I like peanut butter still. So kudos to my parents for making us believe that Peanut Butter August was a glorious celebration and not a punishment. Yeah. Yes?
How would that chart compare to, say, a chart of Sweden?
Oh, question is, how would this chart of determinants of health compare to a chart of Sweden? Well, I'll tell you what. My understanding of these data from Dr. Schroeder is that they would be similar. They would be similar. But here's how we can understand that Sweden approaches it differently. We know that Sweden's economic picture for individuals and families looks a whole lot different than the economic picture in the United States for individuals and families. And we can see that in countries like Sweden, like Denmark, even like the UK, we know that the way that policy, and this is a great, thank you for asking the question, because this is a great segue into sort of the next part of what I wanted to chat about with you this morning. How policy addresses these determinants of health differently, okay? So we know that in some of those Scandinavian countries, now, is everything perfect in Sweden? I mean, they got the great meatballs, so that's pretty darn good. And I say that as a not meat eater even. There's a lot to be said for Scandinavia. I certainly don't want to paint the picture that Scandinavia is perfect, but we know that policy in Scandinavia is geared towards making sure that people have access to the tools and the resources that they need to make those healthy choices, right? From a health perspective. And indeed, we see that reflected in relatively high or long lifespans and overall long years of health. We have a lot of different ways of measuring lifespan, and we have any health economists in the room. We have QALYs and we have DALYs and we have all of these different ways of measuring the quality adjusted life years or disability adjusted life years and things like this. And indeed, countries like Sweden do quite well. Now, there are other issues, there are other sets of vices in places like that. We know that there's relatively high use of like tobacco products, and we know that there's a lot of smoked meats and fish, which lead to higher rates of gastric cancers and things like this. So I don't want to paint like a perfect picture, but yes, policy that's geared toward understanding where we can make impacts, knowing that these are the data, makes a whole lot of sense. So here's how I think about framing policy solutions, but before I get there, let's have one more question here.
Your pie chart I was looking at, it said 10% healthcare, and I assume that's the economic system the healthcare is embedded in, and in our case, it's capitalism. I think that should be a lot bigger. I think it should be like maybe 40 or 50%, because something we seem to be dancing around, and I'm late coming, I apologize. I don't know.
Sure.
If it's
Well,
single payer or public option.
Yes, so the question is questioning the pie chart of 10%. This pie chart, once again, represents all of the things that go into determining one's health and risk of dying prematurely. And there are 5 basic categories. And the category of healthcare, and healthcare is the stuff that we do, including medications, surgeries, physical therapy. That's all the healthcare. All of that only contributes to 10% of health. It is not, so let me just make sure that you then understand that this pie chart this is data. This is data. This does not reflect economics. This does not reflect the money piece of what goes into each of these categories. That is not what this pie chart reflects. You raise the question of, in the United States, so much of our healthcare system is based on capitalism, and yes, it is indeed, but that is not what this pie chart reflects. Okay, so let's talk about how to frame policy solutions. Now, you also, that question, referred to some of the current conversation that we have about how to fix our broken healthcare system. And there are many solutions that are proposed out there. Some people say let the market decide. My very short response to that notion is that health and healthcare does not fall onto the supply-demand curve that you learn in the first day of Economics 101. It doesn't fit into that. If you're making a decision about which toilet seat to buy, absolutely, supply-demand curves give you the information that you need to make that kind of economic decision and that production decision. But health and healthcare services do not fall into a choice-based capitalistic economic chart. So I reject that notion that capitalism and that economic capitalism should be the sole determinant of how we make healthcare policy decisions. Thank you. Yes, there was a moment of clapping, and I'll take it. Yeah, thanks. Then let's think about the other ways that we can think about money and economics, and we will, like, if capitalism is over here, which I realize I'm putting on the left for you even though it's the right for me, so okay, let's put capitalism over here so that it looks right to you. So let's put capitalism over here, and then all the way over here on the left we've got socialism and communism as ways of thinking, not as political strategies or parties. And of course they are political strategies and parties, but let's just talk about them economically. And this notion of, like, the opposite of capitalism, right? There are ways to think about that. However, you noticed that from here, capitalism, that I think we can all in this room agree that this is more or less where we are in America today. I had to come all the way over here, right? I had to, like, pick up my feet and jog a tiny, tiny little bit. Believe me, my Apple Watch did not, like, recognize a lot of steps out of that. But it was a really big transformation to get all the way over here. And here's what I have to tell you. Giant, sweeping changes like that are very rarely the best way to go about making change. And I'll give you the example of, this example I have seen repeated years and years and years, so many times, and it's the example of I am so privileged to be invited into the lives, pardon me, of people who struggle with obesity. And, you know, I am responsible for a piece of their heart health, but we have to always understand that their heart health exists within the framework of really a lot of them to love. And, you know, often I say to my patients, you know, I really would like to see less of you and sooner. Okay, and you know, because we at the end of the day, it usually pays to try to be nice about it. One of the things that I've seen time and time again is a person says to me, well, I just have to make this sweeping change and I'm just going to stop eating. And I say, no, that's not going to work. It's just not going to work. Or I'm only going to eat salads. And once again, oh, that's not going to work either. When it works is when we make incremental change. Because trying to run and leap over to a huge change, it's not healthy for a body, and it's not healthy for a community, and it's not healthy for a society. It's really important to know that that's where we're going. But it's really important to be responsible about how we get there. It's so much safer for me to walk like this than to try to run in heels, okay? So, with that in mind, here's how I think about framing policy solutions. Now, I have spent the last decade of my career doing health policy advocacy at both the state level and at the federal level. And I've shared with you that I am in the process of seeking the approval of my community and really interviewing for this job of the privilege of being able to represent my community and being a big part of these decisions at a federal policy, at a federal level. Here's how I think about policy. I think about policy like a swimming pool. Has anybody ever had an experience that looks like this of your swimming laps in a pool? And I'm talking about literally swimming laps in a swimming pool.
Yeah.
Okay? Yeah. So you know how the swim lanes work. That you stay in your lane, right? So here's how I think about policy. And this fits into how I think about health from a human body perspective and also from a determinants of health perspective. You're supposed to stay in your lane. But while you're swimming in your lane, you're swimming in the same water that all the other lanes are swimming in too. And just because you're in your lane doesn't mean that you can't pop up and take a quick break from your laps and hang on to those lane lines and talk to the person in the next lane over or the lane after that. So I think about policy as a swimming pool with lane lines that are marked, and those lanes can represent municipal, state, federal policy lanes. And it's really critically important that we understand that while we are swimming in our lane, we also are swimming in the same water as everybody else. And if we start thrashing around in our lane, they're going to feel it in the other lanes too. And in order for everybody to get moving together, it works best when we're communicating between our lanes, because the reality is that, and again, I'm a mother, so I've had kids in swimming pools, and you know how that, like, has anybody had that, like, blue dye moment with their toddler in a public pool? You know, so, like, if you pee in the pool, like, that blue dye goes into the next lane over too, right? So it really does impact every decision that we make in our own policy lane, really does impact all of the other policy lanes. I mean, you know, yeah, okay. So if you pee in the pool, it's the same water. Everybody else has to, like, swim in your pee for a little while, all right? And we're all human, so this is a shared experience. Yes, Ruth.
You're bringing up the most important thing, I think, when all these charts make examples of what happens in countries like Norway and Sweden or Lebanon or Turkey or anywhere. They're always have one government, and that government makes policy.
Sure.
And our framers of the Constitution did this wonderful three-part system where you have the federal government and the state government.
Yeah.
And speaking of your pool analogy.
So Ruth points out that in a lot of the countries that we saw in those earlier charts that have, you know, lower healthcare expenditures and relatively better health outcomes, those countries have, you know, more or less one government, which is a dramatic oversimplification, but the point is taken that those are also by and large smaller countries. And yes, of course there are municipal governments, but it's quite different than here in the United States, a huge country, and that was designed to have different swim lanes within this shared pool of the United States that we're swimming in, and it introduces quite a lot more complexity into how we must think about policy. The other thing I want to point out is that it's really critical to remember that individuals have a really important role to play here in the swimming pool. So when we think about behavior, at the end of the day, you know, we as individuals get to choose how we behave. So it's really important to understand the role of the individual in thinking about policy. So I told you at the beginning of this, and am I kind of getting the cane here? How are we on time?
You're good. You got at least like 15, 20.
Okay, so we have some more time. Great. So as we think about, I told you at the outset, we were not going to solve any of these problems, but what I wanted to do was to give a framework of ways to think about how we can go forward and plan solutions for these problems. And it's understanding that there are lanes. So let's think about, from a healthcare perspective, what kind of fits into the lanes, and we can start with the federal lane. From a healthcare perspective, we as a nation have focused a whole lot of energy, all of the energy that we have that's left over after our, 24-minute news cycle of things like, collusion and like court cases and campaign finance violations. When we have like a half a second to refocus and think about, oh my goodness, how are people going to be able to access health care? And remembering that 40% of Americans don't have a $400 put away to cover an emergency. And one single trip to the emergency room would force so many families, almost half of American families, to face the possibility of experiencing homelessness, okay? How can we get past that? And so that's a lot of the, you know, what should insurance look like? Should we even have insurance? Should we continue to have a private healthcare system and a public healthcare system? Should we continue to have a segmented Veterans Administration versus Medicare versus Medicaid versus private hospitals? How should that look? And that is in the federal lane. At the state level, with regard to healthcare, we think about how do states operate Medicaid, okay? And that's been a conversation, and that actually is, there's quite a lot. Medicaid is about half state and half federal, right? It's state administered, but it's federal funds. Most of the funds for Medicaid are federal. So how should we think about that at the state level? But then also remembering the determinants of health, and that 15% that is social circumstances, social conditions, and how does the state factor in with regard to transportation decisions that are made and education decisions that are made. These are state level decisions, and it's so critical to remember that such a tiny portion of the determinants of health are the stuff that we do in the clinic and in the hospital, and so much more of it is outside. So what's in that state lane? And then what's in the municipal lane? Transportation to healthcare services, transportation to and availability to fresh fruits and vegetables, and all of these different things. I was at a wonderful meeting that does fit into this healthcare issue. This was a meeting, it was a community meeting, almost a neighborhood meeting. It was at City Hall in Phoenix, and it had to do with the problem of violence in the transient community. And as a little bit separate from the homeless community, but then understanding the problems of homelessness in downtown Phoenix. And I was so encouraged that when I went to this community meeting, not only were there residents, and not only were there representatives from some of the larger homeless shelters and some of the larger, and some of the food banks and things like this, but also we had elected officials from the municipal level and the county level and the state level and the federal level all having the same conversation. And that's how it has to be. And that's how it also has to be with regard to healthcare. So as we go forward, I hope that indeed this conversation has helped to unravel the mystery and remind us all that there's a lot of fact in there. There's not truly a lot that is mystery, but what it is complex, and what it is interconnected. And we need to remember that all of the water is shared between all of the lanes, and the ripple that we create in one lane is going to spread through to the other lanes. So as we go forward with creating policy solutions, this is how we really must think about it. And this is why, if I bring us back to the beginning of the conversation, this is why it is so critical that we as citizens are involved in putting the people and to selecting the people to serve in the public sphere who are going to not only put their head down and swim in their lane, but are also going to remember that there are other lanes in the same pool, and that in order to elevate the health of the pool, you need to work together with all of the lanes. So, I promised you that we wouldn't solve anything today, and I hope that I stuck to that promise. I feel very confident that I in no way solved the problems. And I hope that and I hope that I helped to frame that the solution to these incredible and sometimes what feels to be paralyzing problems in our healthcare system are not going to be solved with the snap of a finger. And they're not going to be solved by saying, that is where we want to go so I can get there in a single bound. Not even if I were Superman or woman.
Wonder Woman.
Or Wonder Woman. And you probably can't see, my USB drive is actually Wonder Woman.
I love that.
She stays with me. Yes, even if I were Wonder Woman, I could not leap all the way over to where we want to go in a single bound. We must take steps to get there. And it's so important that we take steps in a way that we don't risk, tripping over poor James here in the front row and, and damaging him and breaking an ankle, and going to the emergency room and incurring that, adding to that cost without contributing in a positive way to health outcomes. So you have one more question?
One more about single, your analogy was used in the civil rights here to say that we can't move too fast. We've been trying to give single payer health care for 50 years.
Well, I'm going to push back on you, and thank you for bringing that up. I appreciate that. You mentioned that, and I'm repeating it for the benefit of people who are going to watch this on YouTube or maybe watching the live stream. And I'm so grateful that we have that opportunity to expand this conversation to more eyeballs and, as we say in my house, earballs. The analogy that I'm using was used 50 years ago, more than 50 years ago in the civil rights era, and that and I use the word we loosely, some have tried to get to single payer systems. I would remind us all that in no way, shape, or form does every American feel like they have optimal civil rights today. And I would remind you, in no way, shape, or form does every American feel like they have access to all of the health that they need today. And it is critically important, and I'm going to get a little stern, it is critically important that we not base people's lives on pipe dreams. Pipe dreams are great to dream about, and pipe dreams are great to set goals to. But we have to have the tools to get those goals done. Smoke and dreams does not get the work done, and everybody who goes to work every day, and that is who drives me, and that is who I am fighting for, are the people who go to work every day, and nobody who goes to work every day will come home at the end of the day and tell you that they worked with a dream. Yes?
I was wondering if you thought that it's common for people to talk about the system as being broken, and I think that in a very real sense, the system is absolutely not broken and is extremely efficient and very effective at accomplishing its goal. The problem is that its goal is not to keep people healthy. healthcare in the US is a business,
Yep.
not a humanitarian endeavor.
Yep.
And what is the point in trying to fix things if by fixing it, you're just going to be providing healthcare for people who can't afford to pay for it?
Yep.
They can't afford to immigrate, they can't afford to get insurance, you know?
So-
There's no point in trying to fix that. And do you think it's possible for the system to be fixed in terms of actually providing healthcare for everyone without a paradigm shift in
Yeah.
people viewing medicine as not a business, but as a part of our national infrastructure?
Yeah, thank you. So let me just paraphrase, yes. So yes, please, and people are applauding you, so thank you, and please take
Don't
that
applaud
in.
me, I've given up, I'm trying to immigrate.
No, okay, I mean, let me paraphrase so that, again, the eyeballs and earballs on the interwebs can appreciate the premise and your question. You raised that the way that our healthcare system, and I think we can all comfortably use the word system pretty loosely today, yeah? It's a mosaic if we want to think about it like that. But that our healthcare system, we say that our healthcare system is broken, and I will continue to say that our healthcare system is broken, and I say that from the inside of the system. There's a lot of people, everybody in this room has had some encounters with the healthcare system in some ways. I have had those encounters from every possible direction. And I'm very comfortable in standing up here and saying that there are lots of people in the country and in the world who understand our healthcare system as well as I do. But there's nobody who gets it better than me. There are a lot of people who share that understanding, but I'm up there at the top. And I say that very confidently with experience at every step and every level of the system. Now, that the healthcare system, the premise is that it's not broken, it's working like it's designed to work, and that is as a business. And I'm going to push back on that. The American healthcare system, yes, parts of it do function as a business, but that is not how all of it functions. There are economic realities about doing health care and operating health care, and it's really critical to remember that the way that health care is delivered is by individual workers in the healthcare system, and more workers in the healthcare system than not are motivated other than with dollars. And it's really important to remember that yes, there are aspects of the healthcare system that are really built around money and really built around profit, and it doesn't feel good. For me, that doesn't resonate. And I am very comfortable in sharing with you that I, as a healthcare provider, sometimes to the dismay of my partners in healthcare practice, I am not motivated by making a buck. And I am not motivated by prescribing the newest, fanciest, most expensive medication if there is another medication that is available as a generic and will cost $4 instead of $400 and will yield the same outcome. And I have spent so very much time with individual patients and with families over the years that I have never been compensated a dime for. So I'm pushing back on that because it's important to remember that the healthcare system is not made up solely of shareholders. It's also made up of people who are not motivated by money. Now, that's not to say that it's all a kumbaya, because certainly there are real monetary aspects. And I'll tell you, if a practice can't afford to keep its doors open because of a variety of policy and economic and individuals' capacities to gain transportation to come to a clinic and all of that, if you can't afford to keep the doors open, well, then you don't get to serve anybody. So it's not this swimming pool this water, it's not an either or. It's not an either or. You don't get to say it's all capitalism or it's all socialism. There is a continuum in there. And with that notion, I am getting a very, very enthusiastic sign to wrap this up. So thank you very, very much.
Thank you very much. We're not finished with you yet, so stay right here. So I just wanted to switch to the questions on the microphone and that, so you don't have to repeat every single time, so.
Okay, and we've had such a robust discussion. I think that we can probably just take a couple, yeah?
Couple,
Yeah.
and I'm gonna go back to some questions. But, yeah, you know, one thing I didn't mention in the beginning is a little bit about your podcast that you.
Oh, sure.
Can you just share a little
part
bit
of
while
my
I'm
work
coming
at
back?
ASU includes a podcast called Future Out Loud that you can find at futureoutloud.org. You can also find it in, you know, the iTunes podcast store, a really, you know, a bastion of capitalism, and on SoundCloud and places like that. And there are so very many more hours of me talking about things like this.
Thank you, I just wanted to bring that up. Okay, right back here.
One of the problems I've seen, and I've been a nurse for many years, is that much of our health care is determined by where you live and how much money you make.
Absolutely, yes.
For example, in California, a nurse on the day shift can't take care of more than 4 patients. But in Michigan, the nurses are expected to take anywhere from 8 to 12. On the midnight shift, nurses in Michigan are expected to take care of either 15 or 16 patients. God help you if you manage to get all your meds out. The amount of money spent state to state and municipality to municipality, as well as how much the feds give you based on who you're likely to vote for, is immoral. As professionals, I don't think healthcare people, nurses, doctors, etc., should go along with this way of providing healthcare for our citizens.
So indeed, it's distressing. It's distressing as a healthcare professional, and it's distressing as a member of society to equate life with a dollar sign. And it's deeply troubling in very many ways. I myself have been a nurse on a day shift in Pennsylvania many years ago, taking care of 8 patients on the day shift and 10 patients on the night shift, and those patients could have been ventilated, they could have been on dialysis cyclers, they could have been sundowning, they could have been confused, they could have been trying to pull out their IVs. Or they all could have been sleeping peacefully. I actually don't ever remember that happening. Yes, indeed. And it's really important to remember that's a great example of how these different lanes of policy work. It's a little bit in the weeds, but yes, remembering that Medicare dollars and Medicare spending is appropriated at the federal level, and differentials in Medicare spending at the state level are similarly appropriated at the federal level. However, the scope of practice and the number of patients that a nurse can quote unquote safely care for, that is a state level issue that can be made more liberal, I guess, and I don't mean politically liberal at the so small lowercase liberal, at the institutional level. That's a great example of how, you know, federal and state and local policy all work together to the care of the same patient or the same set of patients. And yes, it is, you know, in a room of people who choose the word humanist as one of the nouns that they ascribe to themselves. I mean, you could have made a choice to be in a room this morning that was the, you know, economist's room or the dollarist's room, right? But you chose to be in the humanist's room, and that's because you really privilege and you choose to focus on the human and on the way that we as humans engage in society and in community and in our nation, whether or not you're trying to make a change to that. But yes, it is troubling. It is troubling indeed.
Hi, as you have that slide, I really like that information. For the house, the behavior counts 40%
Yes.
of the whole house.
Yes.
I'm just wondering, obviously you are very active in this field. I just want to ask, do you know any non-for-profit organization that advocate or help improving behavior in especially maybe disadvantaged community that we as ordinary citizens can help to, so we can contribute the health as a society?
Oh, that's a great question. What organizations, what nonprofit organizations help with behavior to help families? I'll tell you, there are a lot of organizations, a lot of nonprofit organizations that, you know, help to teach sort of behavioral choice making. I think that one of the most impactful places to do that are, and I'm not gonna, you know, name specific, although it would, I'm not gonna name specific organizations, but I'm gonna give you a type of organization that you can locate. Organizations that come to children or that work with children in that early childhood learning period, that 2, 3, and 4-year-old period before children are going into school, and particularly the organizations that not only help give young children those bootstraps to carry them through the rest of their learning life, but also bring their family into the conversation, and in a very gentle way focused on the future of this child, can help to fill in some of those behavioral education gaps that the parents and maybe older siblings and maybe grandparents of that child have. So I think that because those types of organizations come from a place of a young child with all of the possibility for the future, but also bring in people who are already experiencing their future. Those are some of the most impactful organizations, and we see some of those nonprofit organizations in that early childhood education space around some like Head Start programs and things like this. But yeah, great question, thank you. There are so many nonprofits though, and so please do feel free to explore, so all of them. Yes?
Yeah, on the capitalism, socialism thing.
Yes.
Long ago, before Medicare became law, I was in school.
Yes.
My teacher said that Medicare would be socialism, that's communism, and we're all better off dead than red. And her own mother would never take government health care.
Yes.
Flip ahead a while, and I'm talking to an educated man who tells me socialized medicine has never worked anywhere in the world. But just wait till you're on Medicare, you'll love it.
Yes,
I'm not done.
Oh, okay.
So then I had another conversation with somebody who says, no, Medicare is not socialism. our libraries and roads aren't socialism because that's a sensible way to do it. And I just go, how do you have a conversation that even goes to policy?
Yes,
You know,
thank
and
you.
is Medicare socialism, or is that even a good question?
Yes, it's, I think that today, in today's extant conversation, I actually don't think that it's a good question to have today, or to ask today, and here's why. I think that intellectually it's a perfectly good question, but I think that there's so much baggage around that word socialism. It's no longer an intellectual concept. It's just laden down with bags. It's like watching my family try to go on a simple weekend trip to Flagstaff, and we like fill up a minivan. There's just nothing right about that. So much baggage. I'll tell you, it's because of the realities of the conversations that we have today. Yes, that question about socialism, I don't think is a productive question to ask anymore. I wish that it were a productive question to ask. I will share with you that as a healthcare provider, I've had that conversation so very many times with my patients who are doing quite well with their Medicare services, and they admonish me, you know, well, government better keep their hands off my Medicare. And I go, oh, this doesn't make sense. Like, socialized medicine, but you better not touch my Medicare. Oh, for heaven's sake. So the point of your question and your observation is very well taken. It's very well taken. I will also introduce that Medicare is no panacea. I have plenty of patients, and I have cared for so many people who have Medicare, who still struggle and still have to sometimes have been in a position where they've had to choose between buying medicine or buying food. Medicare is not perfect. Medicare is not utopian. And so for all of the people who say that Medicare is the perfect solution indeed, I'm here to tell you, it, as it exists today, is not the perfect solution. Yes, it is so much better than before Medicare, when the most common way to live into one's advanced years was to be drowned in poverty. That's not the America that we want. And it's gotten so much better with Medicare, so much better. And there's so much room for us to continue to improve for everybody. Yeah.
Okay, so we're going to end, she'll hopefully stay for a few more minutes to answer some individual questions, but we're going to go ahead and wrap up. And we have a tradition here at the Humanist Society that we do like to mug our speakers.
Thank you so very much.
Can you please give a big thank you? What a great talk. So stay for a few minutes to answer questions, and I'll let Chris close out.
All right, everybody, thank you so much for coming. This is the end of our presentation. If you'd like to come to lunch, please see Richard. He's the man in the blue shirt up here.